Thank you, Mayor Booker and Jen Childress. Mayor Booker, your leadership in Maywood is a powerful reminder that improving heart health starts at the community level. Today's final session is Connecting the Pieces, bringing health systems, payers, employers, innovators, clinicians, patients, and community leaders together to end fragmentation. Early in this convening, Keith Ferdinand said hypertension is the most potent health risk factor. All of our speakers have pointed out that preventing hypertension prevents strokes, heart attacks, heart failure, kidney disease, and even cognitive decline. We know how to detect hypertension, and we have lifestyle changes and medications that are proven to prevent it. And yet, here we are, in the wealthiest nation on earth, with the most technologically sophisticated healthcare, but only 1 in 4 adults with hypertension have it under control. How can that be? It comes down to priorities. If the key stakeholders jointly made hypertension prevention and control a priority, we can employ evidence-based strategies and therapies to dramatically reduce hypertension. I'm excited about this session because we will shine a light on the Rochester model, a collaborative multi-sector effort that brought together employers, health systems, clinicians, public health leaders, and community organizations in Rochester, New York to improve hypertension control across an entire region. It was the business community, specifically the Rochester Business Alliance, which is the local chamber of commerce, that spearheaded the Rochester model. Led by Wegmans Food Markets, the RBA forged a partnership with the Finger Lakes Health Collaborative, Finger Lakes Health Systems Agency, and area hospitals and leaders to reduce the cost of local health care. They set their sights on reducing high blood pressure. The business leaders examined the costs of care in the community, and they recognized 2 important factors. First, the cost of care for the uninsured, the underinsured, and the Medicare population influenced the business community's cost of care. Second, trying to redesign care just for their employees alone was not effective. This project is unique in that the stimulus and funding for community-wide action comes from the business community. The business leaders saw beyond the often unsuccessful short-term cost reduction programs to construct a multi-year, multifaceted intervention designed to encourage practice redesign and an invigorated community commitment to partnership and accountability. In short, they collectively raised the priority on blood pressure control, and they moved the needle. John Bisognano is a nationally recognized leader in hypertension and cardiovascular care. He serves as the clinical professor of cardiovascular medicine and associate vice chair of internal medicine at the University of Michigan. He's spent his career advancing innovative approaches to improving blood pressure control at both the clinical and community levels. When Dr. Bisognano was at the University of Rochester, he joined forces with Paul Speranza, vice chair of Wegmans, and others to lead the initiative that became known as the Rochester model. I'm pleased to be able to interview John Bisognano for this national forum convening. He is unavailable today, so he and I got together a few days ago to record a conversation. In this edited version of our interview, we began by talking about the economics of uncontrolled hypertension.
Well, thank you. It's a real pleasure to be here, and I appreciate the invitation.
All right. Thank you. Well, earlier in this meeting, we've all heard about innovation and some very exciting innovations using technology and therapeutics, and about leveraging all the players, team-based care, and including community health workers and others in tackling high blood pressure. And then we've also had a session focusing on incentives and incentivizing success in blood pressure management. Now, you and I are having this conversation about pulling all of those things together. And I don't know of a better example of that being done in the real world than the one that you helped to lead in Rochester, New York. You all brought together really an impressive array of stakeholders. And I know that in part because I first learned about your initiative from not someone in public health, not someone in healthcare, but from Paul Speranza, who came from the business world and was at that time, I think, president of the United States Chamber of Commerce.
That's right.
So, John, please start out, if you would, by giving us a thumbnail sketch of the Rochester model and how it came to be.
Well, the Rochester model is very unique because it really started as a recognition in the city of Rochester and the surrounding Monroe County that the treatment of hypertension had plateaued. The successful treatment of hypertension had plateaued. And if we were to pick one of several modifiable diseases to really improve in Monroe County, hypertension was the number one thing that we could do. Other diseases like diabetes and the whole list of diseases were being treated quite adequately and even optimally by our primary care community. But hypertension had a real potential to have an improved treatment that would immediately being over the course of 2 to 3 or 4 years, translate to decreased stroke, decreased heart attack, decreased renal insufficiency. And we were like many other communities in the country. Rochester, New York is a lovely upstate New York community about 250 miles from New York City. And it's similar in size and similar in composition to about 50 other communities in the country. And you could probably think of some in your own states, which have a population of around 200,000 to 300,000, a surrounding area of somewhere between 700,000 and 900,000. And we felt that if we came up with a model that would work in the Rochester, New York area, it is similar to many cities in the country, and this model would be widely applicable.
So, Dr. Bisognano, what was it about the cost of hypertension or uncontrolled hypertension that got the attention of Rochester's employers and caused the Rochester Business Alliance to make it a priority?
Well, I think hypertension is an interesting disease because the cost of treating it is not that high, really, because we're in the great age of generic medications. But the cost of not treating it is sky high because the three things that it prevents is stroke, which has a huge hospital and rehab cost, heart attack, bypass surgery, another again a huge thing, chronic and lifelong dialysis, something that costs between $90,000 and $125,000 per year. All of the sequelae of hypertension are very costly, and besides, just the ethical and philosophical desire to improve the health of the community, the sequela of not treating blood pressure adequately is hugely expensive and puts a drain on the economy of a community, through healthcare costs, through insurance costs. And, if twice as many people in your community are needing dialysis, having strokes, and having heart attacks, and could be prevented, I mean, this is a real line item, so to speak, that's going to drive up your cost of insurance, your cost of healthcare, and it also fills up your hospitals.
Okay, so it wasn't just that hypertension added to the employer's health plan premiums or absenteeism of their employees. It did those things, but they saw a larger, a more macro level cost. Is that what you're saying?
Yeah, it's a much higher cost of not treating it than in other diseases. I mean, you can really see benefits straight away. In this initiative, we had a lot of people who came in with blood pressures far over 160, And bringing people down even to 160 has a profound effect on decreasing stroke rate. And stroke, takes people out of the workforce. It takes them into the hospital, it takes them into rehab centers, not to mention the personal cost of stroke. So this really was a target that everybody could come together and agree on. And we had the good fortune of having the Paul Speranza from Wegmans as being our unifying philosophical force in keeping us on track and really wanting to do a benefit for the community.
Yeah, terrific. So I want to jump back for a second here. You just said there were many people in the community whose blood pressure was above 160. Talk about some of the results that you all collectively achieved through the Rochester model, through this collective impact model.
Well, we were able through the primary care community to bring a lot of people to goal. The number of patients who were treated to goal increased by about 50%. And from a public health standpoint, that's massive.
I want to make sure we heard that right. That was 50%?
Yeah, it went from about 40% up to about 60% treated to goal.
Wow.
Now, that is certainly important, and getting people to goal is absolutely important. But I really want to focus and really why this could be so important to similar communities is bringing people down under 160 has an immediate, a year or two benefit in decreasing stroke rate. And we were able to see that. And you mentioned absenteeism. People with high blood pressure often don't feel well. It promotes heart failure with preserved ejection fraction, also known as diastolic heart failure. These people don't come to work. They miss days. They have other issues that come on. So the business community was, very well aware of the fact of the economic impact this would have on them. But on the other hand, having a relative at home, a father, mother, uncle, grandparent, who's a vital member of the home community with diastolic heart failure, HFpEF, is not a good thing. If you have a family member who needs to go to dialysis, a family member who's had a small stroke, that's something that adversely affects a family, and in the same way that it also affects a business. But I think the group together really, we brought out the best in each of us, and can unify on one specific thing that we know would make our community a better place. And in a community of this size, you can really see benefits that you have made happen. In the treatment of hypertension, it was a matter of, number one, having our primary care community understand what their treatment rate actually was, what their treatment success rate. And once people had a report card of how they were doing, everybody wants to be average or above average. Nobody wants to be in the bottom 50%. So there's a little bit of an understanding, an increased focus on the treatment of hypertension.
If you could just give us a quick overview of who the different players were, who made the Rochester model work, and who played various roles.
It's a wonderful thing in a community the size of Rochester that you actually know the people who you were working with and who are working at the other health systems, because you live in the same neighborhoods. You see your kids at the same middle schools, and you see all of that. And what you find is the healthcare providers in the city really like each other, and they want to accomplish something. They want to accomplish something from a community basis that can help patients and help the public health. And this gave us a forum to come together. So in this were members of the business community, members from Kodak, members from Xerox, members from Wegmans, as well as a number of other ones that I won't name them all, but I don't want to exclude any of them. So members of all the businesses that we could find that were of significant size. And even though the Wegmans Family Foundation was funding it initially, everybody was at the table. Leaders from the healthcare community. And this was a time when, the CEOs of all the health systems would be ready to get together and come together and work on a community project. There's an organization in Rochester, the Finger Lakes Health Services Organization, FLA, HSA, which was really the glue that united this whole group together. It's where the meetings were held. It had community leaders, community groups, community, people from the city council, from the county legislature. So we really had all these people at the table. And they came together with a common goal that everybody wanted, and it really brought out the best in everybody. And this is something that in a city of this size is really effective because the other health systems aren't somewhere 25 miles away. They aren't your competitors necessarily. There's plenty of work to go around in Rochester, and it was just interesting to see this bringing of everyone together, bringing out the best in everyone, trying to achieve a community goal.
And John, you mentioned where the meetings were held. Who met how frequently? And was this a matter of the principals kicking off the initiative and then delegating all of the implementation follow through to lieutenants, or did the principals stay engaged?
Well, the principal stayed engaged, and I would say that Paul Speranza started off as our sort of our philosophical leader, keeping us on track at all times. There were certain key leaders, and from the major systems who would meet periodically, but there were a number of subcommittees that were really empowered to do stuff. A subcommittee on report cards in primary care, a subcommittee on operationalizing meeting patients in their churches, in their barbershops, and there was also an academic charge because we wanted to analyze our data, publish our data, and present it at national meetings in the hopes of getting it out there.
This is a model that works. This is a model that exhibits a different approach, one that fully connects all the different pieces that are really essential to achieve success community-wide and sustained success. And everything in it is applicable. It's every bit as applicable today as it was when this model was launched in the last decade. And our hope with this conversation is that people will learn about it, want to learn even more. By the way, Dr. Bisognano was the lead author of a very important and easy to read article in the Journal of Clinical Hypertension about the model. We have a link on the website for this convening to that article, and I commend it to your attention. Let's talk about those other players in the community. And you just said meeting people where they are. Who else? Who are some of the beyond the box or outside the box components of the initiative, and how did they contribute to the success?
Well, what we did is we empowered certain local community leaders, whether they were pastors in churches, pastors and owners of much smaller businesses. Some of the smaller businesses in Rochester itself and in surrounding communities. Teaching them, and we did have an educational arm about the importance of hypertension. And these are people that when they went back into their community, hypertension isn't that difficult to educate people about. You don't have to go to 4 years of medical school to know the goals, to know what medications can be useful, to know what problems that you're preventing. And we would send people back, and these people had credibility in their local communities, in their neighborhoods, in encouraging people to treat blood pressure. We also made some effort to get into schools, because when kids are coming home saying, Mommy, why do you think a blood pressure of 150 is okay? What is your blood pressure? It sort of raises the awareness in people's individual houses about the importance of treating blood pressure, and also recognizing that blood pressure is something that should be treated, can be treated, and has caused some harm, and perhaps in some of the relatives, to make that link that treating blood pressure isn't just getting a better number, it actually translates. And I think that's the one that educational component was a big step into educating the community that it's not just like taking a pill to get a number better. It's really decreasing stroke, heart attack, and kidney disease. And one thing that I'd mention is we always look toward the goal, of 130, or at that time 140 was also considered a reasonable goal. One of our biggest accomplishments was getting a huge percent of people down under 160. And when you're bringing people from 180 down to 160, you are making a huge impact on decreasing the cardiac and vascular comorbidities. Going from 160 to 140 is good. Going from 140 to 130 is good. But the effort in bringing the 180s and the 190s, which were prevalent in the community, down to under 160, really made an impact in stroke rates. And that was something that was immediately identifiable as a benefit. And again, stroke is one of the most potent motivators in getting people to treat their blood pressure. Heart attack and kidney disease, people would rather not have it, but it's not the same motivator as stroke. And that was an immediate benefit that we saw translated that was motivating people.
Yeah, such a great point. So, Dr. Bisognano, I really like your inclusion of children and the influence that they can have on their families, within their families. It reminds me of how recycling became a thing. It was enlisting elementary school children and learning about recycling and taking that concept home. And now today, it's just one of our social norms. It's part of everyday life. The potential to do something similar with blood pressure management is really exciting. Great place to conclude. John Bisognano, thank you again for participating in the National Forum's mid-year convening. We're excited by the work that you've done to take down hypertension and look forward to working with others to apply it in other communities and expand the success across the United States. Thank you again, Dr. Bisognano.
It's been a real privilege to be part of this. Thank you.